Hello, everybody, and welcome to this edition of the Macro Pro and Friends Summer School Series. I'm Diane Cohen, and today I am joined by Dr. Ron. How are you doing today?
Doing well. Thank you for having me.
Well, we appreciate you joining us during this special Summer School Series. You and I were talking a little bit earlier, and one of the things we do is we start off with a question for our guests. So for those of you that are online, we'd like you to answer this question and put it inside of the question box. I see that somebody just texted us a message, and I will read that in a second. So Dr. Ron, why don't you tell us what the question is, and we can see what people are going to answer.
Okay, my question is, have you had a recent college or high school graduate this summer?
That's a perfect question for summer school. It really is, because I'm sure those kids are really happy not to be back in school. I know my son graduated college a couple years ago, and I don't think it's something he'd like to return to anytime soon. It's a tough thing to do. As you know, how many years of college did you have, Doctor?
Ooh, 4, 1, and 4, so 9.
Oh my goodness, that is a very long time. And we in the workers' comp system want to thank you so much for persevering, because we need good doctors, and we appreciate you being here. All right, so let's just talk a little bit. I'm going to get my housekeeping done, and we'll move on with the rest of the presentation. So today's class is worth 1 CEU. You must be logged on to the GoToWebinar so that they can make sure to take your time in attendance. A certificate will be sent to you in 1 hour, and there'll be a little blue button that says My Certificate in the email. Make sure you click that, and that's where your certificate will pop up from. If you have any questions for Dr., you can certainly ask them. Put it inside of the question box, and we will be glad to ask those questions as we go along, or at the end, whichever works out the best. And there are handouts for today's presentation, so make sure that you download them, because Doctor's got lots of great information. And then lastly, this will be on YouTube, so if you didn't catch something, you want to see it again, well, you'll find it on the Macro Pro YouTube channels. Now, real quickly, I'm going to see what people had to say about the college graduates. So someone said no. So Mirtha, looks like Mirtha, she's got yes, and Christina's got a recent graduate, and now she's excited. She's got exclamation points behind that one. Somebody's nephew did, or somebody's daughter graduated from high school. No recent graduates in their family. Someone put down three. That's a lot for 1 year, isn't it? I think they have 2 nieces out of high school going to college. This person recently got a degree in political science. Well, congratulations, Jacob. How does that work with workers' comp? I wonder what you can do with that. Someone else said they have 2, and Ruth just said they have no recent graduates. So it's kind of fun to see. Someone's godson just graduated from Baylor. So very, very cool. Thank you guys for sharing that. Now that's the same box you're going to put your questions in, should you have any for Doctor during his presentation. Doctor, I'm going to turn it over to you now.
Thank you, and thank you everyone for joining. I am Dr. Ron Heredia, and I hope to share some valuable information with you all today. Title of today's session is Don't Get Burned. We'll discuss detect faking with psychological testing. And I have a QR code on the screen here for you all to see and scan with your phone or tablet if you are able. And the reason for the scan is you'll be able to participate in some questions later in the slides. I will leave this up for just a few more seconds, but no need to worry. The QR code will appear again in a couple of slides, so you'll have that opportunity to scan. Without further delay, I'll present some goals for today's session. I'll introduce myself just a tad bit more. Today's slides will discuss some components of a medical legal psych report, and we will pay specific attention to the psychological testing component of psych reports and the psych evaluations that evaluators conduct. We'll discuss why psychological testing is crucial and who or what specialty will most likely administer and interpret psychological testing. Along the way, I'll throw out some cost-saving tips and strategies for psych claims, as well as some rules and tips for rebutting psych reports and psych doctors' opinions if you ever find yourself in a situation where that it may be necessary. So again, I'm Dr. Heredia. I am the director and owner of Good Mood Legal. We are a psychology consultation practice. We do have 5 psychologists on staff who are QMEs and do some treatment and some other fun type work, fitness for duty evaluations, custody evaluations, personal injury assessments, etc. But I wear many hats in the organization. One of the hats that keeps me the most busy is critiquing psych reports. Psych reports that folks like you all receive and have as a part of your work, your line of work. You may find that sometimes psych reports they seem a little off, or maybe they're not in your favor. And I receive psych reports from claims professionals and attorneys all the time with the email or cover letter saying, I have this psych report, please help. So that's what I thoroughly enjoy doing, providing questions for attorneys to use in cross-examining doctors, writing cover letters or advocacy letters that will be to a psych QME or treating doctor, and more. In addition to my work in the work comp space, I teach psychology at the college level. And I teach a variety of courses. I really enjoy doing that. I'm coming up on 15 years of teaching. My son just graduated high school this June and is off to college. And I shared with him, your college has an opening for a psychology adjunct faculty. Maybe do you think I should join? And he cringed and said, no, please do not do that. He doesn't want me teaching where he's going to school, which is understandable, but it's something that I love doing. I find that there's a parallel between my work with my college students and my work in the work comp space. And the one parallel is the major parallel, psych testing. My students tend to know nothing about psych testing and usually have a lot of questions. And of course, psychological testing is written in as a part of the text and the curriculum. And in work comp, psychological testing is one of the, if not the most important piece of a psychological evaluation and assessment. So definitely we, as work comp professionals who deal with psych claims, should have a good understanding of psychological testing and the do's and the don'ts of psychological testing. And that's what I'm here to provide you with today, especially how to detect faking or malingering with psychological testing results. So again, if you'd like to participate, there is a question coming up in the next slide. And it's really fun when we have audience participation in answering these questions, just like you were so wonderful to answer the question about college or high school graduates this summer in your family or friend group. The question that I pose to you all is, in handling psych claims or working on work comp claims, what are the reasons being identified for you or that you see as the cause of the psych claims that come across your desk? Great, thank you for the participation so far. I'm seeing, we are all seeing the responses on the screen in real time. Administration, pain, chronic issues, harassment, stress, anger, performance, the employer. So the bolded and large font have multiple responses. It seems like stress, pain, and performance, chronic pain and performance are leading responses, which is understandable. I too see many claims of stress as I read psych reports sent to me by other by claims professionals and attorneys, the psych reports written by other PQMEs or psych doctors in the work comp space up and down the state or even throughout the country. Stress claims are huge, especially post-traumatic stress disorder or claims of post-traumatic stress disorder, specifically with PTSD presumption. It's one that I just wrapped up that I was working on for the beginning of this week, and I was able to send it off to the attorney earlier this morning and say, here you go, here's the written analysis on PTSD presumption, where the psych doctor gave a PTSD diagnosis, and it really was not supported in the doctor's report and or multiple evaluations. So I was able to shed light on the major problem areas for the attorney, and I wish them well in deposing the psych doctor with all the questions that I drafted up, and was able to say, these are the questions I would not want to be asked if I was this psych doctor, right? So thank you for participating. We'll have a few more, at least one more question coming up in a few more slides, but I do want to move on and just, I like to start our discussion today with the key phrase, substantial medical evidence. Substantial medical evidence, according to is Labor Code section 3208.3. 3208.3, I'm putting that in the chat, sending it to you all. That's the section of the Labor Code that discusses a psychiatric injury, a compensable psychiatric injury. And the section of the code 3208.3 states, it's pretty lengthy. I don't urge you to go and read that. It'll be quite boring, but I'll highlight two areas of the code that are relevant to today's discussion. One, section 3208.3 says that in order for there to be a compensable psychiatric injury, there must be a psychological disorder. So that's number one. The doctor has to give a disorder in order for it to be compensable. Number two is a two-parter. So the second piece of that section of the code states the psych disorder must come from the DSM. That's part one. It has to come from the DSM. Anybody know what the DSM stands for? Type it into the chat. I'm going to type it in, and let's see who can post it first. I'll type as I read. Diagnostic and Statistical Manual of Mental Disorders. That's the DSM, right? It's a manual, it's about 900 pages. Nobody wants to go and read 900 pages, so I'll kind of shed light on the relevant and important issues seen in the DSM. But we have to know that in order for there to be a compensable psychiatric injury, the diagnosis must come from the DSM. DSM is published by the American Psychiatric Association, but it's used across the globe. It's the Bible of psychology, so to speak. I'll add, when I say that, what I mean is if there is a psychological disorder, it must be in the DSM. If it's not in the DSM, it's not a psychological disorder. With that being said, section 3208.3 goes on to say that there must be a psychological disorder from the DSM. And now that section of the code was written, last updated many years ago, in fact, decades ago. So it identifies the DSM-3R. We are no longer on version 3R. R stands for revised. So version 3 revised is written in the Labor Code. The Labor Code says DSM-3R or a version of the manual that is widely accepted nationally by practitioners in the field of psychiatric medicine. That's a mouthful. I'll say it again. A version of the manual that is widely accepted nationally by practitioners in the field of psychiatric medicine. So the DSM has to be it's a version that is widely accepted by the higher ups and the professionals in psych medicine. Anybody know which version of the DSM we are currently on? The most recently published version? DSM-5 TR. TR stands for text revision. Now, I mentioned to you that the version has to be widely accepted. The DSM-5 TR and its predecessor, the DSM-5, not widely accepted. In fact, you can Google for yourself after today's session, Google a phrase like DSM-5 denounced or problems or controversies. You're going to find pages and pages that come up denouncing the DSM-5 and the DSM-5 TR, which is the text revision of the DSM-5. DSM-5 TR was published in March 2022. It is the most recently published version of the manual. And it's important to note that PTSD presumption law, Labor Code section 3212.15, states the psych doctor must use the most recent version of the DSM. So we have one section of the code that says you have to use the most widely accepted version, and we have one section of the code that says you have to use the most recent version, which is correct, right? I think they hold the same weight. They're both laws or in the labor code. That should be corrected at some point, hopefully in the future. Any lawmakers on the call, please make a note. However, I do want to say that before I move on, that DSM-5 TR and the DSM-5 eliminated the GAF scale. GAF, the GAF. We have to have a GAF in California work comp psych claims. We have to have a GAF score. But if the DSM-5 and the DSM-5 TR eliminated the GAF, how do we get a GAF from the doctor, right? That's one of the major controversies of why those manuals are not widely accepted. They eliminated the GAF. I'll move on. If you have any questions about any of this, please feel free to ask questions throughout the session, or we can wait till the end. I'm open to either. Regardless, the doctor's report is the evidence submitted to the court. The doctor's report is the work product sent to the claims professional, sent to the judge, the attorneys, etc. So the report from the doctor is what we should all be focused on, not the DSM necessarily, not what's in the doctor's head or in their filing cabinet notes, but their report, because that is the work product that was submitted into evidence. So therefore, the doctor's report must constitute substantial medical evidence. That's so important, I'm going to say it again. The doctor's report must constitute substantial medical evidence. How do we know if it does, right? How do we know if the report constitutes substantial medical evidence? You have to read it with the fine-tooth comb, and I'm going to go through in the next series of slides, and I'm going to share some information with you about how you can identify substantial medical evidence in the doctor's report for yourself. First and foremost, it's important to know that a psych report can have data or evidence collected by the doctor and hopefully put into their report in about 5 different sections of the report. Those sections are listed here. I call them 5 sources of data. Every psych report can and should be composed of a section discussing the patient's life history and their presenting complaints or their current complaints. Another section about the results of the doctor's mental status examination. And then in orange and boldface with capital letters, psychological testing. It's so important. As well as a review and discussion of the patient's medical records. And finally, collateral sources of information. Today, I'm going to focus on the psych testing. So I'll briefly tell you what numbers 1, 2, 4, and 5 mean and what you should look for in those sections. First, I'm going to look at my next slide. So first, the patient's life history and their presenting complaints. This is the section of a doctor's report where they discuss where the patient was born, who their family is, where they went to school, all of their work, their military, their medical history, etc. All of the patient's life history, as well as their current or chief complaints on the day of the exam. So important. When I read a psych report, I have one here actually that I was just working on, and for an attorney, I'm going through and I'm highlighting with my yellow highlighter, and I highlight the 1 or 2 word phrases that are actually truly a symptom or complaint. I'm looking at the report here on my desk. It's riddled with yellow highlights of just of the 1 or 2 words that are actually truly a complaint, and really all I've highlighted is about 5 complaints or symptoms. Those are synonyms. Typically, when I read a psych report, they all sound the same to me, just written by different authors, right? Typically, when I read a psych report, this is what it sounds like when I get to that section. The patient complained about being sad and depressed. They reported pain in multiple areas of their body. The patient said they had sleep difficulty and often forgot where they put their keys on a daily basis. That's it. Give or take a few symptoms or complaints. That's all the doctors really give us. And stating it in that manner, there's huge problems when you read a report that sounds like that. The huge problem is it's not a complete or qualitative history of the patient's complaints. The doctor is omitting information about what I call FIDOC, F-I-D-O-C. I'm going to put that in the chat. F is for frequency. It's so important the doctor put in information about the frequency of each symptom. I'll give you an example. When the doctor says that the patient is complained about being depressed, we need to know the frequency of the depression. How often does the patient feel depressed? It would be very simple for the doctor to collect that information. All they have to do is say, patient, you said you're depressed. How often do you feel depressed? What's the frequency? And then the patient might respond every day. Or they might say, oh, about 5 days out of a month. That's a huge difference. We need to know, as the reader of the report, what the information is. And unfortunately, the doctors rarely put that information into their report. That's a huge problem. I is for intensity, same issue. But all the doctor has to do is say, applicant, you said you're depressed daily. On a scale of 1 to 10, with 10 being the absolute worst imaginable, how do you rate the intensity of your depression when you have that symptom? They could say an 11. Or the patient could say, oh, I'd rate it about a 4. Huge difference. We need to know the information. And the doctors just don't put that in their report. The D is for duration. Patient, you said you're depressed every day. When you feel depressed every day, how long does it last? What's the duration? Patient might say 24 hours, doctor. Or they could say, oh, about 1 hour, and then I get going, I get dressed, get myself together, and it goes away. Well, 24 hours, 1 hour, huge difference. We need to know the information. Doctors don't put it in. Onset, patient, when was the very first time you remember feeling depressed or having that feeling? They could say, well, 3 months ago, my dog died. I had my dog for 18 years, and it was my best friend. That was the very first time I had that intense depressed feeling. They could say, oh, it was about a week before I filed the work comp claim. Or they could say, I've been depressed since I was a teenager. I had a nasty parental divorce that I suffered through. So we need to know the information. And then lastly, C is for course over time. I put all of these in the chat for you. Hopefully you can see them. Course over time. In the 2 years that you've been depressed, has your depression gradually gotten better? Has it gradually gotten worse? Did it go away and come back at a certain point? What is the course over time that your depression has taken? We have to know that information. Next is the mental status examination. This is a section in the doctor's report. They must have this section in their report. If not, their report is substantially flawed. A mental status exam, every psych doctor knows how to do one. They all know what it's for. Basically, for your knowledge, mental status exam is when the doctor observes the patient's behaviors, observation of the patient's behaviors only. They should be observing mood, memory, concentration, insight. Put that in the chat. Doctors all know how to do so very quickly and easily. This section of a doctor's evaluation should take about 15 to 30 minutes. They're observing mood, memory, concentration, insight, and judgment. And then they should be describing their observations in the report. I never see the doctor describing observations in the report. Unfortunately, I'm going to read the report I have on my desk for you. I turned to the mental status exam section. It's on page 12. And this is what the doctor says. The doctor says about mood. Mood was characterized by sadness. What did the doctor observe, though, that led them to state that they observed sadness? I don't know what they observed, right? They could be observing tearfulness, themes in the patient's memory of suicidality. The patient had a down, didn't make eye contact, disheveled appearance, so many things, and the doctor didn't describe it. They just said characterized by sadness. Next, let's see, memory. Memory function seemed grossly unimpaired. That's it. That doesn't tell me what the doctor observed. They should state, I observed the patient was able to recall the name of their first grade teacher. I observed that the patient was able to tell me the name of the street they grew up on as a child. I called out 5 objects in the examination room, and the patient was able to recall 5 objects out of 5 after an immediate recall or after a 5-minute interval. Those would be observations that should be described. And all this doctor said was, memory functioning seemed grossly unimpaired, period. Substantial flaw. Before I get to psych testing, review of records, that's pretty easy and simple. It's the doctor should provide a review of medical records. And all you're really looking for in that section is, did the psych doctor, review any other psych reports? Oftentimes you're going to find the answer is no. And then you would be able to conclude there's no data in the medical record review where another psych doctor concurred with his diagnosis. If the doctor did review other psych reports, you want to look to see, did those other psych doctors give the same exact diagnosis? Did they concur with the QME's diagnostic impressions? If no, check no information in the to support the diagnosis from the psych records. We also can check number 2, no information in the mental status exam with observational data to support the doctor's diagnosis. Number 1, incomplete or insufficient information about the patient's complaints to support the doctor's diagnosis. Collateral sources of information. This is when the doctor has to interview the patient's family, friends, or coworkers. Usually this is not necessary and it's absent from reports, which is okay. The doctor would only need to interview the family, friends, or coworkers if the patient cannot speak or think for themselves. In the case of the applicant might be deceased, have amnesia, be the victim of a stroke, or extremely paranoid and hallucinating, which are very rare occasions. So you may never see this in a psych report. Now the important piece, item number 3, psychological testing data. So I'll describe here what you should look for and find in the section about psychological testing. And before we get to that, I'd like to show you this model, the psych diagnosis vulnerability model. In the previous slide, you may have picked up on check, no information in number 1, check, no data in number 2 to support the doctor's diagnosis, no data in the medical record review to support the doctor's diagnosis, no data in the collateral sources to support the doctor's diagnosis. So what I'm getting at here is the doctor's diagnosis in psych reports is rarely supported. In fact, I would go out on a limb and say in the 24 years I've been reading other psych reports, it's about 99% of those reports are lacking in the data. They are significantly flawed and do not support the doctor's diagnosis. Stated a different way, The doctor's psych reports do not constitute substantial medical evidence. So how do you know? How can you tell? And then what does that mean? What are the implications? This model that I created, I feel, illustrates the implications. We have a psych report on the bottom, right? It's a triangle, and resting on that psych report is a psych diagnosis. The psych diagnosis can roll off and fall or crumble to either side, right? We're still going to have a report, but when we have a psych diagnosis that can be discredited or pushed over the edge, what it's going to take with it, the diagnosis will take with it, when we discredit that or nullify the diagnosis, it'll take the causation, gap, disability, apportionment, and treatment conclusions. Those will fall by the wayside if the psych diagnosis is poked and prodded and successfully nullified by perhaps an attorney taking a deposition or a carefully crafted advocacy letter requesting a supplemental report. So causation, gap, disability, apportionment, treatment, those are opinions from the doctor that I usually recommend to attorneys. Do not ask the doctor questions about those conclusions or opinions. Instead, ask the doctor about the psych diagnosis and where in their report is the supporting data for their diagnosis. The DSM, Diagnostic Statistical Manual of Mental Disorders, for every psych diagnosis, it will list all of the requirements or criterion that must be met in order for that diagnosis to be correctly given. I'll give you an example. A major depressive disorder criterion, there are 9 criterion. Number 1 states the person must have depressed mood most of the day, nearly every day. Okay. Well, when I read a psych report, the doctor usually says the person complained about being depressed and sad. They don't say anything about most of the day or nearly every day. Most of the day is duration. How often does depression, the symptom of depression, occur? Nearly every day is frequency, right? How often does the person feel depressed? And when they feel depressed, how long does it last, which is duration, right? So if the doctor does not put that information in their report, we can't say or conclude that the person met the diagnostic criteria for a major depressive disorder. Therefore, I usually recommend the doctor be questioned with a question like, "Doctor, will you please confirm for me that on page 9 of your report, you stated the patient complained about being depressed?" Yes. On page 20 of your report, did you diagnose a major depressive disorder? Yes. I'm handing you a copy of page 160 from the DSM-5 that contain all the criteria for a major depressive disorder. Are you familiar with those criterion? Yes. Okay. Will you read number 1 out loud for the record for me, doctor? Sure. Depressed mood most of the day, nearly every day. Thank you, doctor. Since depressed mood most of the day, nearly every day is the requirement, the number 1 requirement, will you please tell me where in your report I can find information about the frequency of the applicant's depression, about the duration of the applicant's depression, about the intensity, the onset, the course over time, and then what's the doctor going to say? It's not in my report. I can't tell you where that information is. And if it's not in the report, that means that the diagnosis is not supported, and you can poke and prod the diagnosis in that manner with a script of questions, usually about 9 to 11 pages worth of questions that I draft up for these reports, and that's the idea. And I do the same for the psych testing. Question the doctor about their insufficient psychological testing results. So let's go through and identify some of the common red flags in a psych testing report. A credible psych report should have some form of objective psychological testing that can be presented to the court that supports the doctor's conclusions. Now, the key words here are objective psychological data, testing data, right? Objective psychological testing data. What is that? Not every psych test given in reports provides objective psychological testing data. The objective psychological testing data comes from well-researched and respected psychological tests, and not all tests are well-researched and or respected. Here's to lighten the mood a little bit, a funny quote. Who administers and interprets psychological testing? The answer is a psychologist. And now a quote from Harriet Babcock, a author of many psychological tests, the Babcock test specifically, says, a psychiatrist is one who has studied medicine, which he or she does not practice, but practices psychology, which he or she has not studied. In my opinion, there's many truths here. I always recommend when you're deciding on a QME panel specifically, or an AME, go with the psychologist. Here's why. Psychologists have to do 24 months of coursework at the very minimum, and they have to write a dissertation. So they're experienced report writers by putting in data to support their conclusions. That's basically what a psych report is, right? These lengthy psych reports put in all the data to support the opinions or conclusions. Psychologists have that experience by writing dissertations. Psychologists also must take more than one course on psychological testing and become experts in psychological testing. Psychiatrists do not have to write dissertations. They go to medical school, right? They do not have to write dissertations, and they do not have to take courses in psychological testing. If they choose to be overachievers and go and seek out those courses in psychological testing, some may, but it's not a requirement. Another question for us, here goes, pops up. What psychological tests do you see discussed in the psych reports that you've read? Good responses, keep them coming. The psychological tests that you see given inside and discussed in psychological reports. Excellent. It looks like our winner at this point is tied between the MMPI and the Beck Depression Inventory. Good. I agree. Beck Depression Inventory is often used. In fact, in this psych report that I'm reading and analyzing for an attorney today, they give 1, 2, 3, 4, 5, 6, 7, 8 tests. 8 psychological tests were administered and interpreted in this psych report. The report is written by a psychologist, and it is 35 pages long. One of those tests is the Beck Depression Inventory 2. Another one is the Beck Anxiety Inventory. Guess what? This specific psychologist did not give an MMPI. And for that substantial flaw, I'm going to happily share loads of educational information with the attorney and provide them with a script of questions to ask the doctor about their decision to omit the MMPI from their methodology of the psych evaluation and from their reporting. So I'm going to move on. How do I move on? Sorry, I'm trying to change slides here and it's not working for me. Okay. You're probably able to see it change on your end, and my end, it got stuck. But I appreciate your input and participating with these questions. I do want to share with you a major problem. Doctors should never do it, and they often will. And I'll tell you why. So validity scales are so important. The validity scales if they are written into the psych test and that psych test then becomes research and cross-validated across populations throughout the world, that's when the test becomes highly credible. Especially for a medical legal purpose, the MMPI is the #1 gold standard test in all of psychology medical legal evaluations. MMPI stands for Minnesota Multiphasic Personality Inventory. It was created over 75 years ago and has been researched in tens of thousands research articles in peer-reviewed journals. Again, the test considered as the most gold standard or keystone test of all psychological test batteries. MCMI, the Milan Clinical Multi-Axial Inventory, is also credible. The Cattell-16 the TOM test of memory malingering, and the various WACE tests. Dr. Weschler's Adult Intelligence Scale has various versions. So these are the tests we want to look for in psych reports. If these tests, or at least one of them, are not used, the psych report and the doctor's methods have significant problems, and the doctor should be asked about it. So as I shared with you, the psych report that I'm reviewing today does not have an MMPI. And in fact, the doctor gave a personality assessment inventory and tries to make a justification for using that in place of the MMPI, which is a major problem. They didn't do a good job of justifying that, so I'll be able to share that information with the attorney. Now, validity scales. These are scales that first and foremost assess a person's credibility. When the test has validity scales, the test's first job is to tell the test administrator and interpreter and the reader of the doctor's report, frankly, if the person was being honest and truthful or if they were lying and faking. Validity scales will detect that information. On the MMPI, not even a psychologist or psychiatrist has been known to be able to trick that test. So the validity scales are very revealing. And when the validity scales spit out scores after completing the test, it's scored up, the scores come out, and the scores will tell a lot about that person. They'll tell first and foremost, are they faking or are they being honest? Second, if being honest and is a credible individual, the test can go on to say things like the person is depressed or anxious or schizophrenic, they need X medications or they need psychotherapy. The test is very revealing and can identify and pinpoint these issues and these matters with high credibility. There are various versions of the MMPI. The original MMPI, created over 75 years ago. There's an MMPI-2. This is the most widely used version of the MMPI, and it was published in 1989. Even today, in 2024, the MMPI-2 will stand and will hold. It can be used. There is an MMPI-2RF restructured form, and most recently, December 2020, during the pandemic, the MMPI-3 was published. When the scores on any of the MMPIs or the MCMI are, let me just tell you about the MMPI. Scores on the MMPI, MMPI-2, if those scores, it's important that you get your hands on the scores. I've noticed the doctors most recently are omitting the scores from their report. In the old days, back when I started reading psych reports 24 years ago, written by other psych doctors, it was a law. California Code of Regulation 43 stated the doctor must put the MMPI scores in their report, and it stated the doctor must give the MMPI. California Code of Regulation 43 is nicknamed the Psychiatric Protocols. You can still find it in a Google search. It is still relevant to claims with dates of injury prior to 2005. And even though it's not applicable to claims with dates of injury post 2005, that section of the code is still considered in California work comp a standard in the community of psychology and psychiatry. That's also a preface to many questions that I recommend to attorneys ask psych doctors. Doctor, do you agree with the standards in the community of psychology and psychiatry that, right? Do you, doctor, considering that standards in the community of psychology and psychiatry state that the doctor evaluating a work comp applicant should give an MMPI, will you please tell me where in your report you discuss your reasons for omitting the MMPI from your methodology? Will you please tell me where in your report you discuss your decision to decline to give an MMPI, right? That's example of a question that could be posed, especially in this specific case that I'm reviewing where the doctor did not give an MMPI. Now let's say that your report that you're reading, the MMPI was given. Let's say, for instance, the MMPI 2, since that's the most commonly used version. It's important that you get your hands on the scores. I helped an attorney last week and the doctor didn't put the scores in. So I told the attorney, go ask the psych doctor in a phone call or email and say, hey, I noticed that you gave an MMPI 2 and you forgot to put the scores in the report. Will you please fax or email those scores to all the parties and do not submit those scores in a supplemental report since they should have been in your initial report, were omitted? Guess what? The doctor did just that. Sent the scores over, did not write a supplemental report, and tack on a $1,300 bill just to give the scores that they should have already given. So get your hands on the scores, and once you see the scores, you're going to look for the score on scales L, F, and K. L, F, and K. And what you're looking for specifically is the score on any of those three scales 65 or higher? When you find that it is, that means something significant. I'll tell you, an L scale score, according to the psych research, says that the person was not being honest and truthful if it's 65 or higher. An F scale score, 65 or higher, according to the psychological literature, means that the person was attempting to simulate their symptoms. A synonym for that is faking, lying, exaggerating, malingering, whatever you want to call it. The K scale score, 65 or higher, psych literature says that that means the individual was attempting to distort their true clinical presentation. Faking, synonym, right? And then there are similar interpretations for the MCMI, the Cattell, etc. Whenever you find that the individual received these elevated validity scale scores, that means to the doctor, they cannot interpret the clinical scale scores. Clinical scale scores will say things about the individual such as they're depressed, they're anxious, they're schizophrenic, they're paranoid, whatever, they're stressed out, whatever it may be. If the person's validity scale scores show that they were not being honest and credible, the doctor should say nothing about the clinical scale scores, because we can't take those clinical scale interpretations at face value if it's determined the person was not answering truthfully. I'll also say about the MMPI that when the test was created, it was created for, it asked the person to identify their gender. And when it's determined that the individual is answering according to their gender identity, the doctor's scores are going to naturally reflect that's gender identity. So what I'm trying to say here is the MMPI-2 testing manual, on pages 54 and 55, they have two scales, or charts, I should say, two charts. One chart says all the possible scores for a male. The other page chart says all the possible scores for a female. They list all the scores that those genders can get on the MMPI-2. I bring that up for this discussion because I can't tell you how many times I read psych reports and I get the scores for the MMPI-2, and for a Ms. Jones, right, identified as a Ms, And I look at the scores and I match every one, and many of the scores are only possible for a male to obtain. So what went wrong? We could probably never tell, but it's important that the doctor be asked about that substantial flaw. The doctor probably won't know what went wrong, but all we know is the what, right? Not the why that happened, but the what. And the what is the doctor reported impossible scores for the applicant to obtain on the #1 gold standard psychological test. And for that, how do we believe anything in the doctor's report to be truthful and accurate? That would be a very difficult situation for the doctor to answer to. I mentioned earlier the test of memory malingering. This is the TOM, otherwise known as a TOM. It is a good test to use, but it only assesses memory malingering or faking of memory symptoms. A lot of times I see the doctor says something like, the person was credible in all aspects as seen by their scores on the TOM. Well, no, the TOM only assesses if the person's exaggerating or underreporting their memory symptoms, right? Have a good memory or a bad memory. They're having trouble with their memory, this test will tell. But everything else outside of memory, this test will not detect the potential faking or exaggerating of symptoms. The WAIS, Wechsler Adult Intelligence Scale, created by Dr. Wechsler. And what it's important to know about this test is it's lengthy. It's a lengthy test. And so all of a lot actually of the psych doctors that I read that give this test, they describe in their report that they select only a few subscales to administer because they want to shorten the test. And they do that, right? They only give, out of 15 subscales, they only give 4 or 5 at most. Well, what they don't know, or seem to ignore, is that Dr. Wechsler himself, the creator of this test, is noted as early as 1967, quote, reduction in the number of subtests as a time-saving device is unjustifiable and not to be encouraged. By reducing the number of subtests or shortening this test, just because the doctor doesn't want to put the time and work in, will skew the results. And for that reason, the author of the test said it's not justifiable. Some other commonly used psych tests that do not have validity scale. I'll list them today. The Beck Depression Inventory, the Beck Anxiety Inventory. Some other tests that are commonly used in psych reports are the Bender, the Hamilton, Depression and Anxiety, Hamilton's, the Waller, the Sentence Completion Test, the CATS, the Lawton, the Mini Mental Status Exam. Now, these tests do not have validity scales, which means that they are not appropriate for medical legal examinations. Stated another way, these tests we have no way of determining if the person was answering honestly and truthfully to the test items for these specific tests and more, right? This is just a short list. A list of the tests without validity scales goes on and on, is quite lengthy. There are hundreds of them that should never be used in a medical legal exam because we cannot determine if the person was answering honestly and truthfully. So why do doctors give these tests very often? Well, I believe that they may give the test to expand their billing. You know, you may not know this, but in psych, the doctors submit a bill for the psychological testing administration and scoring. So the time spent every 15 minutes, they get to bill for a test administration and test scoring. So why not give as many tests as possible, right? You can maximize the billing in that way. And also it could beef up their report and make it appear as though they have sufficient evidence to support their conclusions. Doctor that I'm working on gave an adjustment disorder with mixed anxiety and depressed mood as their diagnosis, and gave 1, 2, 3, 4, 5, 6, 7, 8 psychological tests. One would look at this and think, oh, this doctor did a significant battery of psychological testing. It probably all shows that the person has an adjustment disorder. Not the case. The doctor did not give an MMPI, gave only the tests similar to those listed on this screen that do not have validity scales. So there's no way to determine if the person was trying intentionally to feign or their symptoms. This slide here, as we come to a close for our hour session, just gives some cost-saving strategies for psych claims that you all might want to take into consideration. I understand that you may have access to these slides, and if you don't, you would like access, you can email me. I created another figure. The importance of carefully crafted advocacy letters. I touched on this a little earlier in the discussion. Advocacy letters is something that I thoroughly enjoy writing for professionals to send to psych doctors. And the places in the process of a psych claim where there's an X on this screen are places where there's potential for an advocacy letter to be sent to the psych doctor. And in these areas of the process of a psych claim, you may consider that, oh yeah, it is going to be possibly helpful to have a carefully crafted advocacy letter that really tells the doctor what is expected, the expectations of how to do their job, for lack of a better term, right? So that we are sure and have a better chance of receiving a substantial medical evidence report from the doctor as opposed to one that does not constitute substantial medical evidence. And lastly, I'd like to give some rules and tips for those attorneys on the call or adjusters and claims professionals to pass to your attorneys on things to consider for questioning psych doctors and taking the psych doctor's cross-examination, how to draft the questions to be used that will really produce some significant outcomes for your side of the case. I really enjoy giving these types of talks, not only to MacroPro and friends who have been so gracious to have me, but also going into offices of claims offices or law offices and doing this in a more intimate personal setting. And these are some of the topics that are available that I'd love to speak on and share information to provide this education to the community. If you have any questions at all or thoughts or ideas and would like to reach out to me in the future, I do welcome that. And I also welcome any questions now if you have any. I know there was a lot of information, and I apologize for that.
It was great information, though. It was fantastic. And I really liked the way that you asked questions and you could see the polls and get that done. You were the first to do that on our programming. So kudos to you. And also congratulations on your son's graduation. That is very exciting. I'm waiting to see if there's any questions that come through for you, since you did ask if there were any. I see a big thank you, Dr. Herrera. But outside of that, I don't see any questions. But if any questions do come in, I'll be sure to share them with you, Doctor. Again, I want to remind everybody that your certificate should show up in about an hour. If you have difficulties with that, please let me know regarding downloading. I can help you for the first month, but after that, I won't be able to assist you. So make sure if you have any issues to let me know. Always check with your ID department first, because it could be a firewall issue, and that's something I can't address for you. All right, everybody, thank you so much for joining us. We do still have 6 more classes in our summer series. Boy, that's like a tongue twister for me today. So if you haven't signed up for them, please go to macropro.com. And again, Doctor, thank you so much for being part of our webinar series. We really appreciate it. We love it when you're in person at our MacroPro and Friends as well. You are a great friend to us. Bye-bye now.
Thank you.